Welcome back to the deep dive. This is where we grab some really technical stuff,
Yeah.
manuals, dense research papers, clinical protocols, and we try to break it down, make it into something useful, maybe if you're prepping for a meeting or, studying, or maybe you're just really curious about how our bodies are put together. If that's you, you're definitely in the right spot. Today, we're diving into, well, a really critical structure, the bony thorax. We're going to spend some serious time looking at like the nitty-gritty of its anatomy, this protective cage thing. And this is a really interesting part, I think. We're going to unpack the procedures needed to actually get a good picture of it with x-rays. It's surprisingly complex.
It really is. It's a fantastic topic. The engineering is just, well, it's elegant. Our sources today are these detailed manual excerpts, right? They walk us through the sternum, the ribs, all those little joints. But like you said, the real core of this is connecting that anatomy, which is pretty amazing on its own, to the really strict positioning rules for imaging.
Yeah.
You almost have to think of it like a 3D puzzle you need to solve to get that perfect photograph.
Exactly. That's the mission today, isn't it? To get past just naming the bones and really understand why things are shaped the way they are, why the joints work like they do. And then, yeah, take that straight into the imaging suite. Why that specific 15-degree angle, why breathe in for this shot, but breathe out for that one. We're trying to unlock the why behind the rules. Okay, let's unpack this. The structure of the human cage.
All right, so starting right at the basics.
Yeah.
The bony thorax. It's essentially this protective shell.
Yeah.
And it's made up of three main things working together. You've got the sternum, that flat bone anchoring the
The
front.
breastbone, yeah.
Right. Then the 12 pairs of ribs wrapping around the sides. And holding it all together at the back, you have the 12 thoracic vertebrae. That's your T-spine.
And, I think most people picture it as like a symmetrical barrel shape, but the source material really stresses it's more complicated. It's conical, narrower up top near the neck, gets wider as you go down. But here's the detail I think people miss. The back part, from the spine around to the ribs, is actually quite a bit longer than the front part, from the sternum back.
That difference in length, front to back, is so important for function and definitely for imaging. Physiologically, that cone shape and the back being longer, it helps maximize the chest volume, lets the lungs expand properly. The whole thing is built for movement, for breathing.
So let's talk functions then. The why. The big one is obvious, right? Protecting the heart and lungs.
Absolutely. Keeps the really vital stuff safe. But it does more. It supports the walls of the pleural cavity that's crucial for the pressure needed to breathe. And it's the main attachment point for the diaphragm, that huge muscle underneath.
Right.
And that connection is what allows for that dynamic function we were talking about, changing the volume of the chest when you breathe. It's not a rigid box at all. It's designed to move.
And those 12 thoracic vertebrae at the back, they're not just, spine bones. They're the foundation.
Exactly. They provide that stable base.
Yeah.
And they allow for that double connection point for the ribs.
Double connection.
Yeah, we'll get into that. But it means the connections are strong, but still flexible enough for that breathing movement.
Okay, let's zoom in on the front then. The sternum.
Right, the anchor.
Oh.
The breastbone. It's flat and narrow right down the middle. About, 6 inches or 15 centimeters long on average. And it seems simple, but it's super important because it gives us those landmarks we use all the time for positioning in X-ray.
And we break it down into 3 parts, top to bottom. Up top, the wider bit is the manubrium. Then the main long section is the body. And then that little dangly bit at the very bottom, the xiphoid process, which isn't always bone, right? Sometimes it's cartilage.
That's right. It often stays cartilaginous until you're, quite a bit older. Then it tends to ossify.
Okay. And where do things attach to it?
So the attachments are really specific. Up top, the manubrium connects to the clavicles, the collarbones. That forms the sternoclavicular joints, or SC joints.
Ah, the SC joints. Okay.
Yeah, right at the upper corners, the manubrial angles. And that's a key connection, linking the whole shoulder girdle back to the main skeleton.
And ribs, which one's attached directly?
Good question. So along the sides of the sternum, it provides the direct attachment point for the first 7 pairs of ribs.
First 7.
Yep. They connect via their own individual piece of costal cartilage.
Costal cartilage, like a flexible bridge.
Exactly. It's cartilage, so it has some give. That elasticity lets the sternum move just a little bit when you breathe in deeply, helps increase the chest volume even more. And because they connect directly, anatomically we call these the true ribs.
True ribs. Okay. Pairs 1 through 7. And you mentioned landmarks, the jugular notch, that dip at the very top.
Precisely. The jugular notch, or suprasternal notch. And just below that, where the manubrium meets the body, there's a slight bump called the sternal angle.
Oh,
Radiographers use those all the time for centering, for finding specific vertebral levels like T7 or T3. They're really reliable external guides.
gotcha. Okay, let's move on to the ribs themselves. All 12 pairs.
Right. The ribs, long, narrow, curved bones. And they're definitely not all identical. There's a pattern. The first rib, pair number 1, it's the shortest, but it's also the broadest. It's almost shaped like a hook, actually.
A hook. Why so different?
It needs to curve pretty sharply to make room for the big blood vessels and nerves, the subclavian artery and vein that pass over it to get to the arm. So it's got a unique shape.
Makes sense. And the others?
Well, as you go down, they get longer. Ribs 1 through 7 get progressively longer. Rib 7 is usually the longest one.
Okay.
Then from 8 down to 12, they start getting shorter again.
And structurally, the source material mentions something about the ends, the front ends being lower than the back ends?
Yes, that's a really important point. The anterior ends, where they head towards the sternum, they naturally slope downwards. They sit lower than the posterior ends, where they attach to the vertebrae.
What does that matter?
That downward slope is what enables the bucket handle motion when you breathe.
Bucket handle.
Yeah, think of a bucket handle swinging upwards and outwards. When you inhale, the ribs lift up and out. And because of that slope, it dramatically increases the side-to-side width of your chest cavity. That's a huge part of getting air in.
Huh. Okay, that makes sense. So the classification system, true, false, floating, that's based on how they attach at the front.
Exactly. It's all about that anterior connection, or lack thereof. So true ribs, we said, are pairs 1 through 7. They connect directly to the sternum with their own cartilage. They form the most stable part of the cage.
Okay. Then the false ribs.
Those are pairs 8, 9, and 10. They don't get their own private connection to the sternum. Instead, their costal cartilage usually piggybacks onto the cartilage of the rib just above it. So 8 connects to 7's cartilage, 9 connects to 8's, 10 connects to 9's. They sort of merge together to form that lower edge you can feel, the costal margin.
Ah, okay, so indirect connection.
Indirect, exactly. And then you have the floating ribs.
Pairs 11 and 12.
Yep. And they're called floating because, well, they only attach at the back to the vertebrae. They have no connection at all at the front, not to the sternum, not even to the cartilage above them. They just end.
Which give them more flexibility, I guess, but less protection.
Precisely. They're much more mobile, which is fine because they mainly sit over the kidneys in the back.
Yeah.
They don't need to form that rigid front cage.
Okay, let's get into the weeds a bit. The structure of a single rib. It's not just a simple curve, is it?
No, definitely not. A
Yeah.
typical rib has sort of 4 key parts you look for. At the back, you have the head. That's the part that actually connects to the vertebral bodies. Then there's a short, slightly narrowed section called the neck. Just past the neck is a little bump, the tubercle. That's important.
The tubercle. Okay.
And then the rest of it, the main curved part, is the body, or the shaft. And the body has a sharp turn in it called the angle of the rib.
Right. And these parts dictate how it connects.
Exactly. The head, at the very back, articulates with the bodies of the thoracic vertebrae. Those are the costovertebral joints. Think of them as the main hinge.
Costovertebral, rib to vertebra. Makes sense.
But here's the really cool part, the second connection point, that tubercle we mentioned.
Yeah.
It articulates with the transverse process, that sticky out bit on the side of the corresponding thoracic vertebra. That forms the costotransverse joints.
Ah. So each rib connects to the spine in 2 places at the back.
Yes, that double articulation posteriorly is like the engineering marvel here.
So,
If we connect this to the bigger picture, that dense network of joints, the 2 connections per rib at the back, plus the cartilage flexibility at the front, that's what makes the rib cage this amazing structure. It's strong enough to protect your heart and lungs from a whack, but it's also flexible enough to expand and contract maybe 50,000 times a day just from breathing.
protection and movement. Okay, I get it. Right, so we've got this intricate scaffold. Now, how on earth do we get a good x-ray of it? Because it sounds like a nightmare, curved bones, soft tissue, other bones in the way.
It absolutely presents challenges. You're right, getting a clear diagnostic image requires really precise geometry.
Let's start with the sternum. The big challenge there, you said, is the spine, right?
Yeah, the number one problem is that the sternum lies directly in front of the thoracic spine, and the spine is dense bone. If you just shoot an x-ray straight through from front to back, AP, or back to front, PA, the sternum just gets lost in the shadow of the vertebrae. You can't see it clearly.
So you have to somehow get it off the spine in the image.
Exactly. You need an oblique view. You have to angle the patient.
And the standard way to do that is RAO, right anterior oblique.
That's the classic projection. PA oblique sternum in the RIO position. This means the patient is lying face down, PA, but rotated so their right shoulder and hip are closer to the table and the left side is lifted up slightly.
Yeah, that's rotation.
Usually pretty shallow, just 15 to 20 degrees.
Why that specific range? Seems quite small.
It's calculated to use the heart shadow. See, the heart sits mostly in the left side of the chest. By rotating the patient just 15-20 degrees RAO, you shift the sternum just enough to the patient's right so that it's projected over the shadow of the heart.
Ah, and the heart shadow is less dense than the spine.
Much less dense. It's mostly muscle and blood, which X-rays pass through more easily than bone. So the sternum shows up nicely against that relatively darker background, separate from the bright white spine shadow.
Clever. But you have to rotate the whole body evenly.
Crucial point. Shoulders and hips must be rotated the same amount. If the shoulders are rotated more than the hips or vice versa, you get this weird torsional distortion of the sternum. It won't look right.
In positioning the actual X-ray plate, the IR.
Precision again. The top edge of the image receptor needs to be about 1.5 inches or 3.8 centimeters above the jugular notch.
Why above?
It's a safety margin. You absolutely cannot cut off the top of the sternum, the manubrium, and those SC joints. So positioning slightly high ensure you get everything.
And the X-ray beam itself, the central ray, CR.
Okay, so for this RAO position, the CR is perpendicular, but it enters the elevated side of the patient's back.
So the left side in an RAO.
Correct. It enters the posterior thorax on the left, about 1 inch, 2.5 centimeters lateral to the midline, the MSP, and you aim it for the level of T7.
T7, why T7?
T7 corresponds roughly to the middle of the sternum. So aiming there helps ensure the whole bone is centered on the image.
Okay, that's the oblique. What about seeing it from the side? The lateral sternum.
The lateral sternum gives you that profile view. Here, the challenge is in the spine. It's soft tissue, mainly the shoulders.
Right, they'd get in the way.
Exactly. So the positioning is all about clearing them. The patient stands or sits sideways to the IR. Shoulders have to be rolled back as far as possible. And the key instruction is for the patient to lock their hands behind their back.
Why lock the hands?
Pulling the arms back and locking the hands pulls the shoulder blades, scapulae, and the soft tissue of the upper arms away from the chest wall. If you just let the arms hang, that massive tissue completely superimposes the manubrium, the top part of the sternum. You wouldn't be able to see it at all.
Makes sense. And the CR for the lateral.
Much simpler. Perpendicular beam entering the side of the sternum right at the level of the mid-sternum, straight in from the side.
Okay, sternum covered. What about those SC joints? Sternoclavicular. They sound small and tricky.
They are. They're small, complex shape right next to the spine and the thick clavicles. Very challenging. Often the first step is just a general look, a PA sternoclavicular joints view, both joints at once.
PA, so face down again.
Yep. Patient lies face down, head resting straight on the chin, so the mid-sagittal plane, MSP of the head, is vertical. The CR is aimed right at the midline at the level of T3.
T3. Okay. That shows both.
It shows both, but they're often superimposed by the spine and ribs. It's a general overview.
So if you need to see one specific joint better, like if someone has pain just on the right side,
Then you have to go oblique again, specifically PA oblique SE joints using body rotation.
okay, another oblique.
But this one, this is one of those positioning rules that really messes with students. It feels backwards.
Oh, here's where it gets really interesting. Lay it on me.
Okay, so you only need a very slight rotation, even shallower than for the sternum, just 10 to 15 degrees RAO or LAO.
10 to 15. Got it.
But here's a kicker. The rule is the affected SC joint, the one you want to see clearly, is placed closer to the image receptor.
Closer. Wait, usually for obliques, don't you lift the side of interest away to open things up?
For many things, yes, but not for PA oblique SC joints.
So if the patient's right SC joint hurts, you put them in an REO position, right side down closer to the IR.
Exactly. Right side pain, RAO position. Left side pain, LAO position.
Why does that work? Why closer?
It's about using that tiny angle to project the shadow of the spine off the joint space you're interested in. By putting the joint of interest closer to the IR, you achieve two things. One, you minimize its magnification and distortion, less object-to-image distance, OID, making it sharper. Two, that slight 10-15 degree rotation is just enough to shift the spine's shadow away from that closer joint. You're essentially using the rotation to move the spine shadow onto the other non-affected SE joint.
Ah, okay. So the rotation isn't to see through the joint, but to move the spine out of the way of the joint.
Precisely. You're isolating the joint closest to the detector, making it free of the spine's shadow.
And the CR for these obliques?
perpendicular again. It enters directly over the SC joint that's closer to the IR. It's usually around the level of T2, T3. Or you can find it by going about 3 inches down from C7, that prominent vertebra at the base of the neck.
Wow. Okay, that is counterintuitive, but makes sense when you explain the goal is spine avoidance. All right, let's shift to the ribs themselves. You said imaging them depends entirely on the diaphragm.
Absolutely. The diaphragm is the dividing line. Are the ribs you need to see above it or below it? That dictates everything, especially the breathing instructions.
How much does the diaphragm actually move?
Quite a bit. Between taking a full breath in and blowing all the air out, you can move, an inch, maybe even 2 inches up and down in the chest cavity. And we deliberately use that movement to our advantage in rib x-rays.
Okay, so scenario 1, we need to see the upper ribs. Let's say ribs 1 through 10.
Right. For upper ribs, you can do a PA ribs view or an AP ribs view. Centering is usually around T7, similar to the sternum level. But the crucial instruction is respiration. The patient must hold their breath at the end of full inspiration. Take a deep breath in and hold it.
Why full inspiration?
Think about what happens. Deep breath in. The diaphragm contracts and moves down as low as it can go. This pulls it away from the upper and mid ribs, meaning those ribs are visualized against the background of the air-filled lungs.
And air is dark on an X-ray.
Exactly. Air provides great natural contrast. The white bone of the rib stands out really sharply against the dark, air-filled lung fields. Maximum visibility.
Okay, makes sense. Inspiration for upper ribs. Now, scenario 2. We need the lower ribs, maybe 8 through 12, especially those floaters.
Okay, technique changes here. For lower ribs, we typically prefer an AP ribs projection, patient lying on their back. And the centering is lower too, halfway between the bottom of the sternum, the xiphoid process, and the body edge of the ribs.
And the breathing, the opposite.
Exactly the opposite. For lower ribs, the patient holds their breath at the end of full expiration. Blow all your air out and hold.
Why expiration this time?
When you breathe out fully, the diaphragm relaxes and moves up, as high as it can go. This pushes the abdominal organs, like the liver on the right, spleen on the left, up underneath the lower ribs.
So you're seeing the lower ribs through the organs. Doesn't that reduce contrast?
It does reduce contrast compared to seeing them against the lungs. The organs create a more uniform gray background. But the advantage is that full expiration guarantees the diaphragm is high up, out of the way, ensuring you can see the entirety of those lower ribs, especially 11 and 12, without the diaphragm cutting across them. Seeing the whole rib is more important here than perfect contrast.
And why AP specifically for lower ribs? You mentioned AP or PA for upper.
Good point. We prefer AP for lower ribs because those floating ribs curve quite significantly towards the back. An AP projection, patient on their back, puts the posterior part of those ribs closer to the image receptor, minimizing that OID we talked about. Less OID means a sharper image of the part most likely to be injured.
Gotcha. Sharpness over contrast for the lower ones.
Okay, what if you need a really specific view of the side of the ribs, like the curve, the axillary portion?
That's when we bring in the oblique views again. And for ribs, it's almost always a 45-degree rotation.
45 degrees. Why so much more than for the sternum or SC joints? That 45-degree angle is typically what's needed to profile the axillary or side portion of the ribs. It effectively rotates the curve so it lies parallel to the image receptor, which gives you the clearest, most elongated view of that specific area, free from self-superimposition.
Okay, so 45 degrees. And we have AP and PA obliques again.
Yep, two main options, and again, the rule about which side is which gets a bit tricky.
Let's break it down. AP oblique ribs. That means the patient is rotated, but their back is generally closer to the IR, right? RPO or LPO.
Correct. Right. Posterior oblique RPO or left posterior oblique LPO. And for AP obliques, the rule is the affected side, the side with the injury or pain, is positioned closer to the IR.
Closer again, like the SC joints.
Yes. So if the patient has pain in their left ribs, you position them in a 45-degree LPO, left side down, closer to the plate.
Why closer for AT obliques?
Again, it's about minimizing OID for the area of interest.
Yeah.
You want the sharpest possible image of that injured axillary portion, so you get as close to the detector as you can.
And you have to move the arm.
Oh, yeah. For oblique ribs, you always have the patient abduct the arm on the affected side, lift it away from their body, and usually rest the hand on their head. Gets the arm and shoulder soft tissue completely out of the way of those side ribs.
Okay. AP oblique, 45 degrees, affected side closer. Now the other way, PA oblique ribs. Patient face down, rotated RAO or LAO.
Right. And here, the rule flips. For PA oblique ribs, the affected side is positioned away from the IR.
Away. So if the left rib's hurt, you do an LAO, left side up.
Exactly. Left side pain, LAO position, 45 degrees.
Why the flip? Why away for PA obliques?
It comes back to projecting the spine shadow. In the PA position, rotating the affected side away from the IR throws the shadow of the thoracic spine further away from those axillary ribs you're trying to visualize.
So both methods, AP with affected side closed, PA with affected side away, are designed to do the same two things. Get the spine out of the way of the side ribs and get the sharpest image of those side ribs.
You got it. Different body positions, same geometric goals. Arm positioning is the same to affected arm up and out of the way.
And breathing for the obliques, does that change?
Nope. Respiration rule stays consistent, dictated purely by whether you're looking at upper or lower ribs.
So if you're doing a 45-degree LPO for injured upper left ribs,
You need full inspiration, diaphragm down.
and if you're doing a 45-degree LAO for injured lower left rib,
You need full expiration, diaphragm up. Location, location, location dictates the breath hold.
okay. That's a lot of rules, a lot of geometry. It really highlights the technical skill involved.
Absolutely. And all that effort is pointless if the final image isn't actually diagnostic. That's where image evaluation comes in. Did we actually succeed?
Right. How do you know if you got a good sternum x-ray? Let's start with that PA oblique, the 15-20-degree RAO.
Okay, checklist time. First, basic stuff. Did you get the whole thing? You need to see the entire sternum, from the jugular notch at the top all the way down to the tip of the xiphoid process at the bottom. No clipping.
Makes sense. What's the crucial check?
The big one. Is it off the spine? The sternum absolutely must be projected over the heart shadow, and critically, it has to be completely free of superimposition from the thoracic spine.
So if you see the sternum overlapping the vertebrae,
The rotation wasn't right, either not enough rotation, maybe less than 15 degrees, or maybe the patient wasn't rotated evenly, causing that torsion. It's not diagnostic if it's overlapping the spine.
Yeah.
You also want evidence of minimal rotation, just enough to clear the spine, not excessively rotated.
okay. And the lateral sternum view, the side view.
For the lateral, the main goal was clearing the shoulders. So evaluation check number 1. Is the manubrium, the top part, free of superimposition by the shoulder soft tissues?
So if it looks fuzzy or dense up top,
The patient didn't pull their shoulders back enough or didn't lock their hands properly. That's a positioning error.
what else for the lateral?
You need to see the sternum truly in profile, free of superimposition by the ribs themselves, which usually means the patient held still during the exposure. And a special consideration for female patients, the lower part of the sternum must not be obscured by breast tissue.
Right, that requires careful positioning.
Yeah, sometimes requires asking the patient to help lift or move breast tissue aside to ensure that distal body and xiphoid are clearly seen.
Okay, moving to the SC joints, that bilateral PA view.
For the straight PA showing both joints, the main check is no rotation. The image should look symmetrical, both SC joints balanced relative to the spine. And technically, the exposure has to be just right enough penetration to see through the spine and ribs, but not so much that you burn out the subtle detail of the joint spaces themselves.
Tricky balance. And the PA oblique SC joint view, that 10-15-degree one where the affected side was closer.
The absolute key criterion here is seeing an open SC joint space. The joint you are interested in should be right in the center of the image, and you should clearly see the space between the clavicle and the sternum. No overlap.
That proves the slate rotation worked.
Exactly. It confirms that small angle successfully projected the articulating surfaces away from each other just enough.
And how does the spine look on that image?
It should show minimal obliquity. If the whole spine looks really rotated, you probably use too much angle, more than that 10-15 degrees, which might actually distort the joint space you were trying to see clearly.
Got it. Subtle rotation, open joint space. Now for the ribs. Evaluating those APPA views seems directly tied to the breathing, right?
Absolutely. This is where you directly check if the breathing instruction was followed correctly. It's written right there in the image.
So if the request was for ribs above the diaphragm,
The image must clearly show the 1st through 10th posterior ribs. You need to see at least 10 ribs fully visualized against the lung fields.
and if you only see, say, 8 or 9 clearly, and the diaphragm is cutting across the 10th,
Then the patient didn't take a full inspiration. The diaphragm didn't go down far enough. Image potentially non-diagnostic for the lower part of that upper set.
okay. And conversely, if the request was for ribs below the diaphragm,
Then you need to see the 8th through 12th posterior ribs clearly, below the level of the elevated diaphragm shadow.
and if the 12th rib is cut off at the bottom or obscured by the diaphragm shadow being too low,
Patient didn't achieve full expiration. They didn't push the diaphragm high enough. Again, potentially missing pathology on those lowest ribs.
Mhm.
If we connect this to the bigger picture, it really shows how vital patient cooperation and clear instructions are. A radiographer can position perfectly, but if the breath hold is wrong, especially that deep inspiration for upper ribs, you might completely miss a fracture on rib 9 or 10 because it's hidden in the diaphragm shadow.
Yeah, the weakest link. Okay, last evaluation. The oblique rib is the 45-degree ones. How do you confirm that angle?
There's actually a measurement check for the 45-degree obliques. You look at the distance from the spine to the outer edge of the ribs on both sides. On a correctly positioned 45-degree oblique, there should be approximately twice as much distance between the spine and the lateral rib border on the affected side. The side elongated, whether it's closer in AP or further in PA, compared to the unaffected side.
Ah, a quantifiable check. Twice the distance means you hit roughly 45 degrees.
Exactly. It's the geometric proof.
And you also need to make sure
Right.
that the axillary portion, that side curve of the ribs you were trying to see, is actually projected clear of the spine. Validates that your choice of AP closer or PA further technique worked to get the spine out of the way. You need that unobstructed view of the curve.
Wow. Okay. So we went from this idea of a simple protective cage to this incredibly detailed anatomical structure, and then into this complex, like 3D geometry puzzle for imaging it, where tiny changes in angle or breathing make all the difference.
We learned the diaphragm is basically the master controller for rib imaging. And for the sternum, you actually use the heart's shadow to help you out. So what does this all mean?
I think it means that every single rule, every procedure we talked about, that 15 degrees for the sternum, the RAO, the breathing in for upper ribs, out for lower ribs, affected side closer for AP oblique, away for PA oblique, none of it is arbitrary. It's all directly driven by the anatomy. Understanding that conical shape, how the ribs slope, how much the diaphragm moves, that's what lets the radiographer make the right choices, apply the physics correctly to get the image. It's physics meeting biology.
That connection, physics and biology. It leads perfectly into our final thought for you, the listener, to chew on. Our source material specifically mentioned that the best way to show the posterior ribs above the diaphragm is using an AP projection after full inspiration. Now, we know AP puts the back ribs closer, minimizing OID, and inspiration gets the diaphragm down. But let's think deeper. The ribs are most curved on the sides, but they flatten out a bit near the spine, posteriorly. So why is that specific combination AP projection, using that flatter posterior part, plus full inspiration considered the definitive choice for upper posterior ribs? Why is it inherently better than trying a PA view, even with full inspiration? What is it about the body's natural curvature in that AP view that just optimizes everything?
Yeah, think about how the X-ray beam interacts with that specific curve in that specific projection. Something to mull over. Well, thank you for joining us on this deep dive into the bony thorax. It was fascinating.
It really was. Until next time, keep digging into those sources.